Yes, madam.
Okay, good, nice. So the objectives we are going to obtain are this to describe the gross morphology, relationships, blood supply of the liver, gallbladder, biliary tree, and the pancreas, and to explain the anatomical basis of the common clinical conditions of the liver, biliary tree, and pancreas. So, just from this lecture, you might not be able to obtain all of these objectives. You will have to cover the histology practicals, the anatomy practical sessions, and you can read around in your textbooks, and you can cover all these objectives with the help of this lecture. So first we are going to talk about the liver. So as you said, the liver is the largest gland in the body. What is the largest organ?
Skin.
Skin. Yes, the largest organ is the skin, but the largest gland in the body is the liver. So it's found in the right hypochondriac region and extends into the epigastric region. So I hope you all know about the different regions of the abdomen. You must already know because you learned about the surface anatomy. Then when you take the liver, there are two surfaces, the diaphragmatic surface and the visceral surface. The diaphragmatic surface is the outer surface and is in contact with the diaphragm mainly. And the visceral surface, it's in contact with the internal organs. When you take the diaphragmatic surface, it is further divided into four surfaces. The anterior surface. So if you look at this image, anteriorly, this anterior aspect is called the anterior surface. And on the right side, you have the right surface. And on the superior aspect, you have the superior surface. And if you look at the posterior view, this area is the posterior diaphragmatic surface. This area is in contact with the diaphragm. And this is the visceral surface in contact with the internal organs. This bare area is in direct contact with the diaphragm and there's no intervening peritoneum in this area. Now we come to the surface anatomy. When you come to the surface anatomy, the upper margin is at the level of the cipisternal joint. Oh, I'm sorry. If you actually draw it, this is your sternum and this is the cipisternum and this is the cipisternal joint. On the middle, you have the, behind the cipisternal joint, you have the liver. And on the right side, it extends up to the fifth rib. And on the left, to the fifth intercostal space. And when you come to the, it curves around like this. And when you come to the right margin, it extends from the 7th to 11th ribs along the mid-axillary line. The line extends from the middle of the axillary region. And when you take the inferior margin, it extends from this point, the right lower end, to the left upper end. And here, below the cipisternum, it has about a hand's breadth. The liver extends about a hand's breadth below the level of the lower end of the cipisternum. And this edge usually follows the costal margin. Okay, so here are some diagrams. So you can see here, you have the cipisternal joint, the fifth intercostal space, and on this side, the fifth rib. And from this side, it extends from the 7th to the 11th ribs. And in this middle area, you have around a hand's breadth below, extending below the cipisternum, and it follows the costal margin. Now, this part is important, has a clinical importance. So, what is the organ in this region? Can someone tell me what is the organ you find here in this area?
Lung.
Yeah. So can anyone remember the level up to which it extends in the mid-axillary line?
10th rib.
10th rib is actually the pleura. The pleura extends, the parietal pleura extends up to the 10th rib. The lung?
8th rib.
8th rib. So usually the surface marking of the lung is 2 less than the parietal pleura. You must be experts on this because you have finished all the lectures and done the dissections, the surface marking, everything. Okay? So here there's a procedure called liver biopsy. In that you insert a needle into the liver and take a small piece of liver for laboratory studies. You can, for like histology, different stains, you can take a small piece of liver. So during that you have to avoid the lung tissue, because if you may mistakenly take lung tissue for the liver biopsy and also cause damage to the liver. So usually this is done at the 8th intercostal space or the 9th, below the 8th rib. It passes through the pleural space, but it's not considered as significance because there's not much damage caused to the pleura. But you have to avoid the lung tissue. And also another point, you don't go beyond 6 centimeters to avoid damage to the inferior vena cava. But from the surface anatomy, you won't get that. But by this, you have to understand, you have to take liver biopsies below the 8th rib. Okay, so this is what I have mentioned. So needle biopsy of the liver is carried out through the right 8th or 9th intercostal space in the mid-axillary line. Then we come to the ligaments of the liver. There are many ligaments which join the liver to the body, the internal surface of the abdomen, and the other organs. Right? You look at the picture. So here in the inferior border, this is the inferior border, at the middle area you have a ligament called the ligament teres. This ligament teres extends from this inferior point to the umbilical region, to the umbilicus. This is a remnant of an embryological vessel. Can anyone remember what that vessel is?
Umbilical vein?
Umbilical vein, exactly, very good. So you have learned about the fetal circulation. So extending from the umbilicus to the lower end of the liver, you have the ligamentum teres, the umbilical vein, which later gets obliterated and becomes the ligamentum teres. Then extending from that upward, you have the falciform ligament. These are extensions from the peritoneum, the parietal peritoneum, and these get reflected onto the liver. So if you just look at the abdominal wall like this, and if this is the liver, you have the peritoneum like this. It comes over the liver and gets reflected like this. So this is the falciform ligament. And on the superior surface, it gets reflected to either side. On the left side, you have the left triangular ligament like this. And on the right side, you have the coronary ligaments, the upper layer of the coronary ligament. So these are the ligaments you can see from the anterior aspect. And if you look at the posterior aspect, here This is the continuation of the upper layer of the coronary ligament. And on its lower end, you have the right triangular ligament. And it extends towards the left side as the lower layer of the coronary ligament. This travels anterior to the inferior vena cava and continues. And in this region, you have the ligamentum venosum. And so covering, it's not marked here, but here you have the ligamentum venosum. And on either side, covering it, you have the lesser omentum, which is again the continuation of the peritoneum. The lesser omentum turns a bit to the right side to cover an area called the porta hepatis, where the arteries and the biliary ducts all come inside and leave the liver. Sort of like the hilum, right? Like the hilum in the lung, where structures enter and leave the lung. In the liver, you have the porta hepatis. And again, here you have the ligamentum teres, which we saw on the anterior side. So this ligamentum venosum, this is again an embryological structure extending from this area, the ligamentum teres, and it enters the inferior vena cava. Can anyone tell me what is the vessel which gives rise to the ligamentum venosum? The structure which carries blood from the umbilical vein to the inferior vena cava?
Ductus venosus.
Ductus venosus, yes, exactly. So these 2 points you have to remember because it's usually asked then to understand better, right? So those are the, you can work it out as well. So you have the ligamentum teres, umbilical vein, and then you have the ligamentum venosum or ductus venosus, which carried blood from that to the inferior vena cava. So those are the ligaments. Then you have the lobes. So anatomically, the liver is divided into 2 main lobes, the right lobe and the left lobe. These are divided by the ligamentum teres and the ligamentum venosum, and anteriorly by the falciform ligament. So if you take the anterior side from this line and posteriorly this line. And you have 2 special lobes called the caudate lobe and the quadrate lobe. So in the anatomical division, it is included to the right side. Right side. So here you have the caudate lobe and here the quadrate lobe. So superiorly you have the caudate lobe. You can remember it because C comes early in the alphabet. It's located superior. That's how I used to remember. But when you divide it functionally according to the blood supply, the caudate lobe and the quadrate lobe belong to the left lobe. So the functional division occurs at a oblique plane like this. Extends from the inferior bed of the inferior vena cava to the bed of the gallbladder. This is the line dividing the functional functional lobes. You will understand more as we learn about the blood supply. Yeah. So here we have the segments. These lobes are further divided into segments according to the blood supply. There are 8 segments, and the caudate lobe, here you have the caudate lobe, it is the first segment, and then the other lobes are located in an anti-clockwise direction. If you look at it, here you have the segment 1, 2, 3, 4, 5, 6, 7, 8, like that. They are located in an anti-clockwise direction. The fourth lobe, the quadrate lobe, is called 4B, and it extends upwards like this, but generally you can take it extending in an anti-clockwise direction. So this is how you see it on the anterior aspect. the first globe you can't see, but the other ones you can see from the anterior aspect as well. So you have the blood vessels. You have two arteries, two blood supply to the liver by the hepatic artery and the portal vein. They usually go in the same pathway, share a common pathway, and the bile ducts also drain in a similar pathway. So they usually supply each segment like this. Okay. But the hepatic veins drain between these segments. If you remember the blood supply of the lungs as well, you had the bronchi and the pulmonary arteries supplying the segments, and the pulmonary veins drained between the bronchopulmonary segments. Like that, here also it's same, right? The veins drain between the segments, and the arteries and these ducts each supply one segment. So when you come to the blood supply, you have the hepatic artery. The hepatic artery is a branch coming from the aorta and the celiac trunk. Yes, here happens picture. So here is the aorta, the celiac trunk, and you have the hepatic artery here. It supplies oxygenated blood. It's rich in oxygen, and it is the source of 30% of the blood supply to the liver. And at the porta hepatis, it divides into two: the right hepatic branch and the left hepatic branch. And these are usually end arteries, and they don't have anastomosis within the liver. So because they are end arteries, the liver segments might be susceptible to ischemia, right? Loss of blood supply and cell death. Then what about the rest of the blood supply? It comes from the portal vein, right? So here you have the portal vein. The portal vein drains obtains blood draining from the GI tract, from the stomach, the small intestine, and the large intestine. So these absorb digested nutrients. And from all these regions, they take the digested blood rich in nutrients to the liver. It also divides into two branches, the right and the left, at the porta hepatis. So this blood is not rich in oxygen because the oxygen has been used up by these cells of the GI tract. It's rich in nutrients. Then you have the hepatic veins which drain the liver. So these vessels, as I said, these are found between the segments. They usually have three tributaries: the right, the left, and the middle. And within the liver substance itself, it drains into the inferior vena cava. And then we come to an important clinical point again. You have portosystemic anastomosis. So there's the portal system which drains from the GI tract to the liver, and the systemic veins are the usual veins, the inferior vena cava, the azygous system. That system drains the usual blood of which oxygen has been used up by the organs. So there are anastomoses between these two venous systems. If we talk about where those anastomoses are found, the first one is at the lower end of the esophagus. You have the left gastric vein tributaries here, and also the esophageal veins of the azygous vein draining this area. Then at the upper end of the anal canal, the superior rectal vein belongs to the portal system, while the middle and inferior rectal veins drain to the internal iliac vein and the common iliac vein and into the inferior vena cava. So here also you have another anastomosis. And then you have the bare area of the liver, where you have hepatic veins of the liver and the phrenic veins draining the diaphragm region. Then this is the periumbilical region. You have the paraumbilical veins going along the ligamentum teres. And then on the anterior abdominal wall, you have epigastric veins. There are superficial and deep epigastric veins which drain into the iliac veins, internal and external iliac veins, and drain into the inferior vena cava. You also have other retroperitoneal areas. Okay? For example, for the ascending colon, descending colon, you have the pancreas, spleen, all those areas. You have branches draining to the portal system. These are called retroperitoneal veins, which some also drain into the systemic venous system, right? To the retroperitoneal veins of the systemic veins. So in a normal person, these don't carry much of an importance, but in some diseases, there is fibrosis of the liver tissue. That means the normal liver tissue gets replaced by fibrous tissue, and these veins, the portal veins, get blocked, and the blood starts to get collected in these portal veins, and as they can't drain through here, through the portal vein and liver substance into the hepatic vein, they start to drain through these anastomosis into the systemic venous system, right? So the nutrients, and you may have toxic metabolites, everything bypasses this liver and enters the systemic veins. This is to keep the circulation ongoing, but it has bad effects because all those toxic metabolites are not processed in the liver, and they directly enter into this systemic venous system. And because blood travels through these anastomosis, they start to dilate. So in the normal person, they are not very prominent, but if the blood starts to travel through these anastomosis, they start to dilate and cause various symptoms. So you can read up on all these, but I will tell you one example. Here in the esophagus, the lower end of the esophagus, these veins dilate and result in esophageal varices. So this, in this image, this is an endoscopic view where you enter a camera through your esophagus, through your mouth into the esophagus. So this is a normal esophagus, and this has a small amount of dilated veins, you can see around here. And here the veins are dilated further, and here you have a lot of dilated veins and there's bleeding here. So this occurs due to a blood being carried through these and various anastomoses. So this is a small homework for you, and you go home. So after the lecture, as you are already in your homes, you can fill this chart, right? You can, I have mentioned the anastomosis. You can read what are the portal tributaries, what are the systemic tributaries, and what are the clinical consequences which occur when they are blocked, when the portal venous system is blocked. Then if we talk a little bit about the porta hepatis, the porta hepatis is where the structures enter and leave the liver, and it is enclosed by the these two peritoneal layers which form the lesser omentum. So from this area, the lesser omentum extends to the lesser curvature of the stomach. You have the hepatic ducts, the branches of the hepatic artery, branches of the portal vein, and you also have lymph nodes and nerves which enter and leave the liver here. So we come to another clinical correlation, the Pringer's manual. So the structures of the portal hepatis enter into the lesser omentum like this, and here you have the lesser omentum extending from the liver to the lesser curvature of the stomach. So in the free end of the lesser curvature, here there's a small foramen which enters into the lesser sac, right? This is called the foramen of Winslow, right? And along this free edge of this lesser omentum, you have three structures traveling. You have the bile duct, you have the portal vein, and the hepatic artery, which is a branch of the celiac trunk. So most posteriorly, you have the portal vein, and anteriorly, on the right side, you have the bile duct, and on the left side, you have the hepatic artery. So in Pringer's manual, it's done to stop bleeding within the liver. During surgery, to stop blood supply to the liver, and if there's trauma and bleeding from the liver, you can do this maneuver. You insert your finger into the foramen of Winslow from here, and then press on these structures, the portal vein and the hepatic artery, and this stops the pauses the blood supply to the liver. So when you come to the lymph drainage, in the porta hepatis, you have lymph nodes. So the lymph of the liver drain into the nodes of the porta hepatis, and then to celiac nodes which surround the celiac trunk. Here you have lymph nodes. Okay, so anyway, you have the these follow the arterial supply, right? From the porta hepatis, they go along the hepatic artery to the celiac nodes, and along that they join the thoracic duct and drain the lymph. And also there's another area of lymph drainage from the bare area of the liver, which was in direct contact with the diaphragm. From there, lymph drain with the diaphragm and surrounding organs to the posterior mediastinal nodes. So lymph drainage is important to know because cells like cancer cells and infections may spread along lymph. So therefore you have to know about the lymph drainage. And then about the nerve supply. The sympathetic nerves you have from the celiac ganglia, and the parasympathetic supplies from the vagus from the hepatic branch of the anterior vagal trunk. So the nerve supply is involved in the control of the arterial diameter, right? Contraction and dilation, restriction and dilation of the blood vessels, and also it controls the bile flow. It's not as important as the enzymes, but the nerve supply also plays a small part. Okay, so now we come to the structure of the liver, that is the microscopy, right? So when you talk about the microscopy, you have the liver substance are arranged as hepatic globules. And so if you take one hepatic globule, you have in the center you have a central vein like this, and on the peripheries you have portal triads. In these regions you have portal triads. In these portal triads you have three things: a branch of the hepatic arteriole, and a branch of the portal vein, and a bile ductule. So you have these three structures which are called the portal tribe at each of these ends. And from the periphery to the central, you have hepatocytes arranged radially like this. And in between these areas, you have branches entering from the hepatic artery and the portal vein. Right? Blood enters like this, and they get mixed also, and they gradually travel towards the central vein. And in between hepatocytes, you have the bile canaliculi, which travel through the hepatocytes and enter the bile ductules like this. Bile canaliculi. Right. So here you have a diagram. So here you have the portal tribe with the branch of the bile duct, hepatic portal vein, and the hepatic artery. Here you have the common area of drainage of the portal vein and the hepatic artery. These are called sinusoids. So these hepatocytes are covered with sinusoids filled with blood. Okay? Then between the hepatocytes, you have the bile ducts. Here a portal triad is shown, and the portal vein, a bile duct, and the hepatic artery, and also you have lymphatic vessels, small lymphatic vessels within. Here is the central venule and hepatocytes arranged radially. In these also you can see here, this is the central vein, sinusoids and hepatocytes. This is a section of the human liver. The hepatocyte, the portal triad, the hepatic globules, these are usually considered as hexagonal shapes, but in the actual structure, they are not very well organized. They are shaped varially like this. Again, here you can see a view of the liver from a laser magnification. You can see hepatic globule, central vein here. These are various ducts. When you look at the structure of the hepatocyte, so here you have a sinusoid filled with blood, right? So on that surface, and these are the endothelial cells. So you have different types of endothelial cells, right? In the liver, you have sinusoids. And between these endothelial cells and the hepatocyte, you have a small space which is filled with plasma fluid coming from the blood. This space is called the space of Dissay. And then you have the surface of the liver cell, which has small microvilli, small processes, which are called microvilli. These are irregular. And when you look inside the cell, you have a large nucleus, and it may be binucleate. You can have more than one nuclei. And these cells may have more than one set of chromosomes, more than 2 sets of chromosomes. Because these cells are used to a lot of work, lot of protein synthesis and making a lot of enzymes. So they have a lot of DNA. And they have a lot of mitochondria, a rough endoplasmic reticulum for protein synthesis, and a lot of SCR, smooth endoplasmic reticulum, for the processing of various substances, detoxification, and making bilirubin and all the stuff. Actually, glucuronidation of bilirubin. I think you will learn all those things in biochemistry, right? So yeah, you have various storage granules as well. You have glycogen granules and you have lipid droplets. And here you can see the bile canaliculi. So you find the bile canaliculi between the hepatocytes or the liver cells like this. So the liver cells secrete the bile into these bile canaliculi. What is? Yeah, you have otherwise the phagocytic bacterioles and the lysosome to digest various molecules. So the bile canaliculi, which were found between the hepatocytes, drain into small canals called canals of Hering. These are the canals of Hering, and they drain into the portal tract. Yeah, this side. So here is the portal tract. You have the bile ductule here. Bile travels along the canals of Hering to the bile ductule. So from the bile ductule, they collect other bile ductules, get larger and gradually drain to the left and right hepatic ducts. So we talked about the classic hepatic lobule, right? With the central vein in the center and the portal tracts on the corners. So these mainly describe how the venous drainage occurs, right? Artery, from the arteries, the blood drains into the central vein. This shows how the blood drains into the central vein. When you take there are another few divisions how we can divide the liver. Liver microscopically, you have the portal lobules. The portal lobules travel from the hepatocytes, these organized radially from in this direction. So the portal lobules show how the bile is drained, right? So bile produced from the hepatocytes gradually travels in this direction and drains into the hepatic ducts by bile ductules to the hepatic ducts in this direction. So this is triangular shape. And you again have another method of division. It's called the hepatic acinus. The hepatic acinus is diamond shape and it shows the blood supply. How the blood from the hepatic artery and the portal vein is supplied to the hepatocytes. So they start from here. The hepatic artery and the portal vein start from here and gradually drain into the central vein like this. And these areas are divided into 3 zones. Zone 1 is very rich in blood oxygen from the hepatic artery and very rich in nutrients. And as you go to zone 1, they are less oxygenated. So the function of hepatocytes changed according to their zone. So in this zone 1, you have a lot of oxygen and processes that need lot of oxygen like protein synthesis happens in this area. And in zone 3, there's less oxygen and things which need functions which need less oxygen happens in this region, such as glycolysis and lipid synthesis, right? And if there is less blood supply, if there's an obstruction of blood supply to the liver, the most susceptible area to be damaged is this zone, the zone 3. So here you can see the space of Dissay between the endothelial cells and the hepatocytes. And there are 2 more types of cells within the liver, the Kupffer cells and the stellate cells. Kupffer cells are found within the blood, within the sinusoids, and they are modified macrophages. They phagocytose all red blood cells and bacteria, things like that, and digest them, right? And these are the stellate cells. They have many fat droplets. attributes like this, and they store fat soluble vitamins like vitamin A, D, E, and K. They store in these cells, and when there is damage to these hepatocytes, these stellate cells start forming extracellular matrix and fibrous tissue to replace them. Right? So then we come to the biliary system. Biliary system is how the bile is drained from the liver. Right? So you have the bile canaliculi draining into the bile ducts, and then the for the hepatitis, you have two bile ducts draining the liver. You have the right hepatic duct and the left hepatic duct. They join and form the common hepatic duct here. Right? And then you have joining it the cystic duct. The cystic duct drains the gallbladder. Then the cystic duct and the common hepatic duct get together and form the bile duct. So these are the parts of the biliary system. So usually the bile duct travels in the free margin of the lesser omentum, as we saw earlier. The part of the bile duct can be divided into three. This part traveling in the lesser omentum, and then you have the second part traveling behind the first part of the duodenum, and then the third part behind the head of the pancreas or embedded within the head of the pancreas. And it opens into the middle area of the second part of the duodenum at the ampulla of Vater. So you have a sphincter here, sphincter Oddi. So the sphincter of Oddi is normally closed. Then the bile get accumulated in the gallbladder here. And when it gets accumulated here, the water and excess water will get absorbed to the gallbladder, and it will concentrate the bile. So the function of the gallbladder is to store and concentrate bile. And when you have fat, you have food within the duodenum, especially lipids, you have an enzyme called the cholecystokinin released, and it stimulates the gallbladder to contract. At that time, bile enters the duodenum and helps to digest the lipids. So here you have the gallbladder. It's a pear-shaped organ, and it has a capacity of 30 to 50 milliliters. It stores and concentrates bile, and it can be divided into three parts: the fundus, body, and the neck. So this is the fundus, this is the body, and this is the neck. The neck gradually turns into the cystic duct. The fundus projects below the low inferior margin of the liver. Right? And it comes into contact with the anterior abdominal wall. And when you take the surface marking, it is at the tip of the 9th costal cartilage on the right side. So you can see it coming beyond the inferior margin of the liver here. And this can be located from the external surface by palpating the tip of the 9th costal cartilage. So when there is inflammation of the gallbladder, that is this disease causing diseases like infection, there will be inflammation, and if you press on this area on the tip of the 9th costal cartilage, there will be sudden pain. There will be tenderness, that is pain on palpation, right? So if there's inflammation of the gallbladder called cholecystitis, you can identify it by palpating this area. Then when you talk about this arterial supply, it is supplied by the cystic artery, which is usually a branch of the right hepatic artery. So you have the right hepatic artery here, which is the branch of the hepatic artery coming from the celiac trunk. You have the cystic artery. So this is the usual anatomy, but it can have many variations. It can come from the hepatic artery itself. It can come anterior to the bile duct, common hepatic duct. It can curve around, coil around the bile duct like this. There are many variations. It's important to know about these variations because in some conditions you have to remove the gallbladder. Like when there's stones causing symptoms or infection, as I said, cholecystitis, you have to remove the gallbladder. And in that case, you have to ligate the cystic duct and the cystic artery. These two have to be ligated and cut off, right, to remove the gallbladder. So then you have to be careful not to damage the bile duct and the other hepatic arteries. Therefore, you have to know about these variations. Then there's an area called the Callan's triangle. Callan's triangle is formed by the lower, in the inferior surface of the liver, the common hepatic duct here, and the cystic duct here. So this landmark is used to identify the cystic duct and the cystic artery. So surgeons use this triangle to identify these structures and carefully ligate them without causing damage to this bile duct and the hepatic arteries. Then when you come to the venous drainage, you have multiple veins which drain directly into the liver substance like this. Right? So this is the main method of how the gallbladder drains blood. And also you can have a cystic vein along the cystic artery. It drains into the portal vein and again enters the liver. So when you come to the nerve supply, you have sympathetic supply from the celiac plexus and parasympathetic supply from the vagal fibers. So these to some extent control the bile, gallbladder contraction and control of the blood supply to the gallbladder. They are not that much important because gallbladder contraction is mostly controlled by the hormones, right, like cholecystokinin. Then pain, it travels along the sympathetic fibers to T7 and T9 area. So it's the pain from arising from the gallbladder is felt along the T7 and T9 dermatomes, right? Usually in the right hypochondriac region. And also there is a afferent pathway from the phrenic nerve. So the phrenic nerve rises from C3, C4 and C5. And usually the dermatome of that area is the right shoulder, right? So pain from the gallbladder can be felt on the right shoulder as well. And that's called referred pain, I'm sure you know that. Then about lymphatic drainage, you have the cystic lymph nodes in this triangle, in the Kalletov triangle, and they follow the hepatic artery and the lymphatic drainage of the liver to the hepatic nodes and the celiac nodes. Now, if you look at the gallbladder structure, when you look at the mucosa, it's drawn into folds, especially when it's contracted and not distended with bile. You can see drawn into folds like this. And on the surface, you have simple columnar epithelium. And in the submucosa, you have elastic fibers, many blood vessels and lymphatics to absorb water and concentrate the bile. you have many blood vessels and lymphatics, and you have a muscular layer in which there are muscle fibers arranged in 3 directions. You have muscles arranged in longitudinal, in transverse, and in oblique directions. These are not formed in distinct layers, but muscles going in all these directions can be seen in this muscular layer. And outside you have a thick adventitia, a collagenous tissue, which helps to attach the gallbladder to the liver. Then, if you look at the clinical correlations of the gallbladder, you can have stones forming within the gallbladder. If they are too much concentrated, then if there's too much cholesterol, it can be formed into stones. So, stones remaining in the gallbladder without causing any symptoms is not a problem. The problem comes when they start to cause symptoms. So, one such symptom is a biliary colic. Biliary colic occurs when one of these stones gets stuck in the gallbladder neck or in any part of the biliary tract, in the cystic duct or the bile duct. They can block the biliary system, and when it is blocked, when you have contractions of the gallbladder will try to somehow get rid of the bile, and this excessive contraction will cause pain. So that's biliary colic. And then obstructive jaundice. And if there's obstruction for a long time, the bile will get accumulated here, and it will get accumulated in the hepatic ducts, and it will have no way to drain, and it will get reabsorbed into the livers. So it will cause obstructive jaundice. Again, in biochemistry, you will learn this thoroughly. You have to know in and out about this obstructive jaundice. Then another thing called gallstone ileus can happen. These stones can ulcerate into the transverse colon or the duodenum. So when you look at the structure of the gallbladder, here you can see that it is associated with the duodenum and the transverse colon or the hepatic flexure of the colon. So these stones can get ulcerated and enter these structures. If it enters the transverse colon, it may pass through with the remaining digested food through the anus, and it will get removed. Then there will be no problem. But if it enters the duodenum, it may travel through the small intestine and get stuck at the ileocecal junction. If that happens, there will be obstruction of the intestine. The food cannot pass through the ileocecal junction, and it will cause dilatation of the small intestine and will cause problems, right? So that's what happens in gallstone ileus and acute cholecystitis, inflammation of the gallbladder. So if these gallstones damage the gallbladder, there can be cholecystitis, and if there's infection introduced, also there can be inflammation, that is cholecystitis. That will also cause pain on the right hypochondriac region, and also it can radiate to the right shoulder. Okay, so now we come to the pancreas. Pancreas is an elongated structure which extends from the epigastric region to the left upper quadrant. So here in the duodenum, it is the head of the pancreas is lodged within this curvature of the duodenum like this, and it extends into the left upper region. hypochondriac region. It is found in the posterior abdominal wall and it's a retroperitoneal structure. So the lesser sac and the stomach, all these structures are anterior to the pancreas. The pancreas crosses the transpyloric plane at L1 level, right? When you take the parts of the pancreas, you have the head, the neck, the body and the tail. And from the head, you have a small extension coming here, which travels behind the superior mesenteric vessels, which is called the uncinate process. And the pancreas has exocrine and endocrine components. Exocrine means it's the enzymes. Enzymes are produced and is secreted into the duodenum. And endocrine component releases hormones into the blood. When you look at the pancreatic ducts, you have the main pancreatic duct system extending from the tail to the head like this, and it enters the it joins the bile duct here and opens into the middle part of the duodenum at the major duodenum papilla, where you have the ampulla of Fortin and the sphincter of Foddy. And the uncinate process may drain separately through the accessory pancreatic duct to the minor duodenal papilla. Okay. And you can have various connections between these two ducts. So if we look at a bit at the how this origin, in the embryo, you have two buds for the pancreas, two pancreatic buds from the ventral side, that is the anterior side, and the dorsal side. Right? You have two buds like this, and as if you look at a cross section like this, you have the buds like this, and as the development occurs, the left side travels grows at a much speed level than this right side. So this moves to the dorsal aspect like this. Right? So this dorsal bud gives rise to the main part here. This gives rise to the main part here, and this ventral bud moves to this side and fuses to form the uncinate process and the lower part of the head like this. So you have the duct of the ventral part here, duct of the dorsal part here, and later during development these two get exchanged, right? So that's how the main pancreatic duct coming from the, which arise from the dorsal pancreatic bud, drain to the major duodenal papilla, and the part from the ventral bud drains through the axillary duct more proximal to the major duodenal papilla, like this. Okay. So we come to a clinical correlation again. Cancer head of pancreas. So in the head of the pancreas, there can cancer of the head of the pancreas can occur. So you know cancer is uncontrolled growth of cells. And here, when there's uncontrolled growth of cells, it can obstruct these ducts. And it will cause obstruction of the bile duct as well as the pancreatic ducts. And when there's obstruction of the bile duct, it will again impair the drainage of bile and cause obstructive jaundice. And another point, the tail extends up to the spleen here, right? So when there's damage to the spleen or in any disease of the spleen, you might have to remove the spleen. And in those cases, you have to be careful not to damage the pancreas. So damage to the pancreas will cause release of enzymes into the body cavity, and it will be disastrous, right? So there are amylase, lipases, and it can digest internal organs, and it will cause peritonitis, inflammation within the peritoneum. So you have to be careful not to damage the spleen, the pancreas during removal of the spleen. When you come to the arterial supply of the spleen, it is again from the celiac trunk. So you have the left gastric artery here, the common hepatic artery, and the splenic artery. So the splenic artery supplies the neck and the tail region of the spleen. Then from the common hepatic artery, you have branches, the superior pancreato-duodenal arteries. Right? You have anterior and posterior branches of the superior pancreatico-duodenal arteries. And from the this superior mesenteric artery, here you have the superior mesenteric artery, and from there you have inferior pancreatico-duodenal artery, the anterior and the posterior branches. Then if you come to the venous drainage, it's similar. You have the splenic vein, which drains to the portal vein, the superior pancreatico-duodenal veins, and the inferior pancreatico-duodenal veins, all draining into the portal system. Right? The inferior veins drain to the superior mesenteric vein, which joins with the splenic vein from the hepatic portal vein. Then the lymph drainage is to the celiac nodes, right? Along the splenic artery. You know, the splenic nodes, and they basically follow the arteries, right? So you have the superior mesenteric nodes in this region, and they enter the celiac nodes and the pre-aortic nodes and drain to the thoracic duct. The nerve supply is again from the splanchnic nerves from T6 to 10. And the parasympathetic supply is from the vagal, and the pain nerves follow the sympathetic nerves from T6 to T10. So if we look at another clinical correlation in pancreatitis, the pain is referred to the epigastric region. T7 to T10 region, here you have the epigastric pain, and because it's located deep, just anterior to the vertebral column, so it's retroperitoneal structure behind the peritoneum, and it compresses the spinal nerves there, and so the pain can be referred to the back. So these kind of patients are usually bending forward. They are holding their epigastric region and bending forward, because by bending forward, the pain caused by the pancreas pressing on the spinal area is relieved. So now if we look at the structures, as we said, there's an exocrine component and an endocrine component. Exocrine component, it's a system of duct and acini. Right? You have rows of cells and small acini. So you have acinal cells like this. So these secrete enzymes into the ducts, and the enzymes travel through the ducts to the gradually to the sphincter of Oddi, to the ampulla of Vater, right? So these cells have a lot of protein synthesis. So they are usually basophilic. And between these acini, there are a lot of acinal cells. You have another important areas which are called islets of Langerhans. So these islets of Langerhans is where the endocrine component is. You have staining cells which produce hormones. There are 3 types of cells here: alpha cells, beta cells, and delta cells. These alpha cells produce glucagon, beta cells produce insulin, and the delta cells produce somatostatin. So here you can see the acinar cells. Here. All these are acinar cells. Here, these are the acinar cells. And these are the ducts between the acinar cells. Here you can see a islet, pancreatic islet. And these have all these 3 types of alpha, beta, and delta cells. So the pancreas has a thin capsule, and it's arranged in different lobules like areas, and these lobules are separated by septate, the collagenous tissue extending into the substance of the pancreas. And within these lobules, the cells are closely packed together. The acinar cells which produce the enzymes are closely packed together, and there's a highly branched duct system which drains the enzymes produced by these cells. So here you have a duct system within it. So here you have an interlobular duct shown. And these cells have a lot of RER, rough endoplasmic reticulum, and the mitochondria to produce the enzymes. And they have many zymogen granules which store the enzymes and release them into the ducts. Here again, here you have been shown an islet of Langerhans, and around it you can see the exocrine component with the acinar cells. So if you talk about another correlation, if there's trauma or anything happening to the pancreas, if there's inflammation or damage to the cells in the pancreas, it can occur in blunt trauma because it's close to the vertebral column. If there's blunt trauma, it can get compressed against the vertebral column and get damaged. And during stab injury or gunshot wounds, if there's something like that, the pancreas can get damaged and the pancreatic enzymes can be released. This will cause pancreatitis, and as the enzymes are released, it will cause damage to the surrounding structures as well and cause peritonitis. So these are the references I have used. Thank you.